Welcome to This Week in Hematology. This week we're covering 8 notable papers spanning severe aplastic anemia management, acute myeloid leukemia prognostication and measurable residual disease, and plasma cell dyscrasias. Let's dive in. In the realm of bone marrow failure, optimizing initial immunosuppression remains a critical clinical goal. The Phase 3 randomized Superiority, EBMT-SAAWP race study evaluated the addition of Eltrombopag to standard horse antithymocyclobulin and cyclosporin A as first-line treatment for severe aplastic anemia. With 197 treatment-naive patients followed for a median of 23.2 months, the 2-year cumulative incidence of complete response was significantly superior in the Eltrombopag arm at 62.4%, compared to 35.3% in the standard arm. Furthermore, disease-free survival and event-free survival were both significantly superior with the addition of Eltrombopag, and overall survival showed a favorable trend of 91% versus 86%, with an adjusted hazard ratio of 0.54. Importantly, the addition of Eltrombopag did not increase the risk of clonal evolution or secondary myeloid malignancies, establishing a more effective frontline standard. Turning to acute myeloid leukemia, several studies this week refine our understanding of risk stratification, measurable residual disease, and mutational profiling. In leukemia, the French VENAURA registry retrospectively analyzed 220 newly diagnosed acute myeloid leukemia patients treated frontline with azacitidine and venetoclax who achieved composite complete remission. Achieving measurable residual disease negativity by multiparametric flow cytometry, or NPM1 quantitative PCR, was strongly associated with superior overall survival and a lower cumulative incidence of relapse. Dual negativity for leukemia-associated immunophenotypes and leukemia stem cell markers conferred the best overall outcomes, and measurable residual disease responses successfully mitigated the adverse prognostic impact of European Leukemia Net intermediate and poor risk categories. Complementing these findings in the American Journal of Hematology, Bolarinwa and colleagues examined the prognostic value of routine next-generation sequencing data in 545 patients with newly diagnosed acute myeloid leukemia treated with intensive 7+3 induction chemotherapy. They demonstrated that the prognostic value of specific mutations is largely limited to primary non-core binding factor acute myeloid leukemia, where adverse karyotype and mutations in KRAS, TP53, and TET2 predicted inferior survival, while FLT3, ITD, or NPM1 FLT3 co-mutations predicted superior complete remission rates and survival. Notably, post-myeloproliferative neoplasm acute myeloid leukemia carried dismal outcomes and should be prognostically separated from post-myelodysplastic syndrome disease. In plasma cell dyscrasias and multiple myeloma, therapeutic advancements and screening strategies continue to evolve across multiple journals. In Blood Cancer Journal, Kumar and colleagues investigated a fixed-duration quadruplet regimen containing daratumumab, ixazimib, lenalidomide, and dexamethasone in 78 newly diagnosed multiple myeloma patients, evaluating early steroid discontinuation in a sequential cohort. The overall response rate was 96%, with a complete response rate or better of 32% and nearly a third of patients achieving bone marrow minimal residual disease negativity. Early discontinuation of dexamethasone, down to just 2 cycles in cohort B, did not impact efficacy, and progression-free survival remained robust with finite duration therapy. Expanding into relapsed and refractory settings, Al-Kazaki and colleagues published a descriptive pooled analysis in Blood Advances, evaluating BCMA-targeted therapies in 256 patients with immunoglobulin light chain amyloidosis. Chimeric antigen receptor T-cell therapies, bispecific antibodies, and antibody-drug conjugates all demonstrated high overall response rates of 83% overall, with 92% for chimeric antigen receptor T-cell therapies and 89% for bispecific antibodies, alongside deep hematologic responses and significant organ recovery, particularly cardiac responses in 41% of evaluable patients, accompanied by manageable safety profiles. For patients with Waldenstrom macroglobulinemia and immunoglobulin M-related peripheral neuropathy, Gavriatopoulou and colleagues reported in the British Journal of Hematology on 28 patients treated primarily with rituximab-based regimens, demonstrating significant and sustained improvements in both inflammatory neuropathy cause and treatment scores, and rash-built overall disability scale scores over a 2-year follow-up, correlating directly with immunoglobulin M reduction. Finally, looking at familial predisposition, the same group published a prospective study in Blood Advances screening 2,481 first- and second-degree relatives across 864 families with plasma cell dyscrasias. Active screening identified monoclonal gammopathies in 11.3% of families, yielding 41 new cases of monoclonal gammopathies at a rate of 4.7% per family, which is roughly double the risk observed in control spouses, supporting the clinical value of familial screening for early detection. In lymphoma, Hugh and colleagues evaluated upfront autologous stem cell transplantation in first complete remission for advanced stage extranodal natural killer T-cell lymphoma in a multicenter retrospective study. Reviewing 107 patients across 14 medical centers in China who achieved first complete remission, 36% received upfront autologous stem cell transplantation consolidation. Progression-free survival and overall survival rates were significantly higher in the transplantation group, with 3-year progression-free survival reaching 78.2% compared to 54.6% in the non-transplantation group. In multivariate and propensity score matched analyses, upfront autologous stem cell transplantation remained an independent predictor of superior progression-free survival, particularly among patients receiving non-anthracycline-based frontline chemotherapy. If you only have time for one paper this week, make it the RACE study Phase 3 trial. It provides definitive, long-term, randomized evidence that adding Eltrombopag to standard immunosuppressive therapy nearly doubles complete response rates in severe aplastic anemia, without increasing secondary clonal evolution, permanently shifting frontline standards. Here are the key takeaways from this week in hematology. Eltrombopag, combined with horse anti-thymocyte globulin and cyclosporin, significantly improves complete response and event-free survival in frontline severe aplastic anemia without raising secondary malignancy risk. Achieving measurable residual disease negativity in venetoclax-treated acute myeloid leukemia overrides baseline European leukemia net risk categories and predicts superior survival. Quadruplet therapy with daratumumab, ixazomib, lenalidomide, and fixed short-duration dexamethasone yields deep responses and marrow negativity in newly diagnosed myeloma. Upfront autologous stem cell consolidation significantly prolongs progression-free survival in advanced stage extranodal natural killer T-cell lymphoma in first complete remission. Active screening of relatives of patients with plasma cell dyscrasias reveals a doubled prevalence of monoclonal gammopathies, supporting targeted familial screening. That's your roundup for this week in hematology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials,